So our next presentation is by Dr. Cristina Cusin. She's the founder and director of our ketamine clinic at Mass General. And she's really a tremendous innovator. She was the first one to develop actually an intranasal ketamine clinic in the country. And she's also director of translational studies in the Depression Clinical Research Program, or the CRP at Mass General. Chris actually got her medical degree at University of Milan in Italy and came to the US to repeat her training in psychiatry. She had to do it, unfortunately, but there was a requirement. Joined the depression program as a staff psychiatrist and has dedicated her career to working with patients with the most severe form of depression. This mission led her to working with ketamine, which is a drug traditionally used as an anesthetic. It's also a drug that has been used for abuse purposes, but has shown great promise in the treatment of resistant depression. She's involved in many clinical trials exploring new treatments for depression, and she launched the Ketamine Clinic at Mass General in 2015, and in 2018 opened up the IV Ketamine Clinic. She will talk to us about her work with ketamine as a researcher and a clinician. Ketamine from research to clinical practice is the topic of her presentation. Please welcome Dr. Cristina Cusin.
Thank you. Thank you all for being here. Thank you so much for hosting this and for your support. It's been great. Great experience for me, great learning experience to be here with all of you. It's my first time, so a little emotional. Why am I here? Let's start from the basics. I'm here because I trained in Italy. I was working in a specific unit where there were admitted patients with bipolar disorder and depression. So I started working with patients who were already hospitalized, and even throughout the hospitalization, there was not much we could offer because they already tried and failed the common treatments. So I trained in electroconvulsive therapy, and I started to notice that the patients with the most severe forms of depression didn't even respond to that, which is the gold standard, is considered the most effective treatment we have. Fast forward, I moved here, repeated my training, worked again in the ECT service at Mass General, and I started to notice exactly the same pattern, where patients were milder form of disease, the first episode, the acute illness, they were getting better, and patients with the most chronic, nasty forms of depression, not so much. They were accumulating a lot of side effects, but they were not really getting better. So I'm here because I want to research how to approach, how to treat the patients with the most severe forms of depression. If you can think about the equivalent of a stage 3, stage 4 cancer, those patients are routinely excluded from clinical trials from pharmaceutical companies because they're too sick. Can you imagine in oncology if we could exclude all the patients with stage 3, stage 4 cancer because they're too sick for researching new drugs? It doesn't make any sense in any other field of medicine. Yet this is what pharmaceutical companies have done for decades. So I came to the DCRP inspired by Maurizio's work, 3 decades of work in depression, developing new treatments, working with pharma, working in trying to make a difference. So for those patients, we have drugs, electroconvulsive therapy, TMS, different forms of psychotherapy, and that's about it. That's where we're stuck. So this is, if you think depression was identified in the ancient Greece, the description of the syndrome has not really changed in 3,000 years. We know what depression looks like. And for about 3,000 years, we kept the patients safe. We locked them up in asylums in the 1800s, or just did nothing because we had no options whatsoever. We started in the 50s having tricyclics, having the first drugs discovered by chance where they were looking for antihistamines. They were looking for different type of treatments. They were looking for antibiotics. And they found out by chance that some of those antibiotics actually helped severe depression. And then tweaking the molecules, found different classes of antidepressants. In the 80s, Prozac came along. It was great because it was easier to prescribe, less lethal in overdose. So the primary care physicians could feel comfortable in prescribing. But again, it was similar mechanism. It was not that different from the drugs that came before. It was safer, but the mechanism of action on dopamine, norepinephrine, serotonin were always the same. And then in the early 2000s, we started having some report that patients who were taking very small dose of an old anesthetic called ketamine were feeling better for a period of time. One dose was sufficient for days or sometimes for weeks to make them feel better. It was initially sort of discarded as an oddity until the National Institute of Mental Health had some researchers who started to take this seriously and do control studies, first versus placebo, and the patients, even if they have failed other antidepressants, were still reporting to feel better for weeks. And then we tried in more controlled studies with active placebos, with drugs that could really confound, and the patients weren't sure whether they were taking ketamine or they were taking another anesthetic. And the patients who were taking ketamine, regardless of the dose, they were still getting much better than the patients taking the other anesthetic. So there was something unique about ketamine. And this is when I decided to start working on a drug that could potentially be helpful, even to the patients who had failed many other treatments, who had failed ECT. Keep in mind who comes to Mass General. It's considered the Mecca, the ivory tower. Our patients are different from the patients that are seen in the community. They are not eligible for clinical trials. They have failed a lot of treatments. Our colleagues refer them to us because they don't know where to turn anymore. They're hopeless, they're desperate. They are being told, sometimes it drives me crazy, they're being told by their psychiatrist, there's nothing that can be done for you. You just don't do that. It's horrible, you don't do, and especially because it's not true. It's just, this is what really enraged me when I hear that a patient was told by their physician, there's nothing that can be done for you. So we had to design our own clinical trials, because there was no clinical trials where we could send them. So we started figuring out and trying to get funds from foundations, the American Suicide Prevention. How can we design a clinical trial that actually is tailored to the needs of our patients, instead of trying to fit our patients into the mold of other clinical trials? So this is the story, and then I'll backtrack a little bit, telling you about the story of a patient. Since those early studies, we started having patients who were getting so much better during the clinical trials, and they relapse. Ketamine is a drug, it's not a miracle. Once you stop taking it, it stops working. It doesn't continue indefinitely. So what is worse, not providing any help or providing a little help for a month and then withdrawing it? To patients who are suicidal and desperate, it's really a bad idea. So we felt the need that we have to be somehow able to offer this in the context of clinical practice, in the context of longitudinal care. And we opened in 2015, after many meetings, many committees, many efforts, the first ketamine clinic for the patients coming out of clinical trials. If you got better in the trial, we'll continue to offer you ketamine so you can continue to do better and live your life. And then more meetings, more committees, we're able to open the intravenous ketamine clinic, where we can treat 9 patients at a time instead of 1 per week or so. So having the ability to treat 9 patients twice a week was a dramatic change in my life and my ability to provide care. And since the opening, we have been treating now over 770, performed 770 infusion, about 120 patients, and has been great. The demand continues to increase. The little side note, the Janssen pharmaceutical company has been working on a slight variant of ketamine. They patented, it's called Spravato. They got the FDA approval in March, and it's so expensive that no insurance is willing to cover it. So we're trying to figure out some way to offer the FDA-approved version, but so far has been not successful. We've been working on this for months and months, and we're still nowhere near being able to provide the FDA-approved version. So we delivered a generic version because, again, we are focused on how to help people, regardless of how we have to do it and what kind of barriers we have to overcome. I wanted to show you the other peculiar effect we have observed on ketamine. This is one of the earliest studies. You see the level of severity of suicidal ideation. It goes from 0, I have no suicidal thoughts, 1, I have some fleeting suicidal thoughts, through 3, 4, 5. 5, I made up a plan. It's not as much about intent, but how much details I put into my plan, and I want to kill myself. So the patients enrolled in this early trial were all chronically suicidal. They had to be suicidal for at least 3 months in a row, more days than not, in order to get into the study. And a lot of them reported that with repeated administrations of ketamine, they no longer felt suicidal, in a way that it was completely separate from the effects on depression. We have always been taught that depression and suicidal thinking goes hand in hand. In order to improve suicidal thinking, you have to improve depression. The patients would come out after an infusion of ketamine and say, "Doc, there is something weird. I don't want to kill myself anymore, and I don't know why." And we were just baffled, saying, "But you're still depressed, right?" "Yes, I'm still depressed. My life is exactly the same. Nothing has changed. I just don't want to kill myself. The pain is not so intense that I want out of here." So we tried to figure out, could this be a treatment specifically for the patients who were chronically suicidal, not acutely suicidal, there's something happened in their life and they're in the emergency room for an acute crisis, they need to be in the hospital. But we have, at Mass General, we have a lot of patients who are colleagues, they're doctors and nurses, and they work in pharma, they're CEO. They just struggle day in, day out to go on with their life. They say, "I want to kill myself, I will never do it because of my children, because of my family. I just put up a facade and go on, but I'm miserable." And ketamine was the first thing that alleviated those thoughts. So I wanted to show briefly the story of Sarah. Sarah is the daughter of a diplomat, grew up in a country in Central Africa. She had horrible experiences, witnessed guerrilla and murders. She was kidnapped and held in the jungle for days, was assaulted. She had one of the worst PTSD I've ever seen and horrible depression. And she participated in one of the earliest studies on ketamine. And for the first time in about 3 decades, she was not suicidal for a month. She was one of the person who mostly pushed me to the idea of trying to find some way to offer ketamine long-term, because a suicidal ideation of this intensity that lasted for decades and resolved with one treatment for me was unprecedented. There's still a lot of work to do. She's working with DBT therapists, she's in maintenance, she's doing trauma work, but she is now volunteering, she has artwork, she has a line of jewelry. The quality of life is completely different. So ketamine has been, if you remember Oliver Sacks and the movie Awakenings in 1990 with Robin Williams, has been the equivalent. Oliver Sacks described the brain as the most incredible thing in the universe. She worked with survivors from an encephalitis and tried to administer levodopa. Those patients were all of a sudden talking again, living again. And the challenge is they were robbed of years of their life because of their illness. So they had to figure out how to live a life anymore. They had to figure out what to do now that all their relationships were destroyed. They had no job. They had no friendships. For some patients, ketamine has been a gift that allowed them to go back to a life after missing a decade or more because of the depression. It works for about 50% of the patients. It works sometimes within a day. It works better with repeated administrations. Each dose lasts about 2 to 3 weeks, long after the drug has left the body, so we don't fully understand how it works. Ketamine half-life is about 4 hours. Within a few hours, the ketamine is gone, but the antidepressant effect, I've seen it lasting for 5 weeks. So it triggers something in the brain that we don't fully understand. The demand, as mentioned, is increasing. A lot of patients would like to be able to try it because the depression has not improved with anything. We have a lot to do. We don't know exactly how it works. We can't predict who's going to get better, so we have to keep it open and say, well, let's try it, but we don't know if it's going to work for you specifically. Is it working better in young people? Is it working better in middle-aged patients? Does PTSD make a difference? Does anxiety make a difference? We don't know. Does medical conditions make a difference? We had some patients with cancer and severe depression, with heart conditions and severe depression. So we're still trying to understand how does it work. what's the right dose? The initial study picked a dose out of thin air because it was borrowed from the anesthesia literature. So we are the first group that studied 4 different doses of ketamine versus an active placebo to maintain it. And all the doses of ketamine were better than placebo. So we don't know exactly what the right dose for each patient is because it was not developed for depression. It was developed on anesthetic. And we don't use anesthetic doses. We use much lower doses. Could it be a pill? Right now it's only intravenous or intranasal because the oral absorption is not good. So we're trying to figure out if a pill form could be possible, or a patch. Maybe it's more practical than having an intravenous infusion. And how does it work? We're trying with MRI studies. We're trying with pharmaco-MRI study to figure out a little bit more because the mechanism we hypothesize are from rat's model. And you cannot tell me that this rat is depressed, that you stress a rat and you say, this is a model of depression. It's just, sorry, I don't believe that. It doesn't work. We need to study in patients, but we don't have access to the primary organ we're studying. We can't do brain biopsies like an oncologist. They do liver biopsies, kidney biopsy. We cannot do that. We have to find some more refined tool. And then the biggest goal that we have right now is to train the next generation of physicians because we're so few of us that can deliver this treatment in a safe way, in a way that is rigorous and collecting side effects and drug interactions, and we need to do much more of this. I just wanted to leave you with a quote from a patient. He sent me an email last week. He's an accomplished writer and college professor, and I was just impressed by this quote. That this is his way of saying, pleasantly surprised that it's working, but terrified that it's going to stop working, and he's going to have nothing beside that. Thank you so much for listening.